Assalamualaikum warahmatullahi taala wabarakatuh. Salam sejahtera dan selamat petang. Hari ini saya akan beri sedikit penerangan berkenaan dengan Safe Surgery, Safe Life programs di Hospital Tanah Aminah, Johor Bahru. Terlebih dahulu saya rasa semua kenal saya siapa. Saya Dr. Isyamuddin, Ketua Jabatan Ortopedik Hospital Tanah Aminah, merangkap pengurusi Safe Surgery, Safe Life Hospital Tanah Aminah Johor Bahru. Saya telah memegang jawatan ini saya rasa sejak 2019 dan akan berakhir pada Januari 2023 lah tempoh saya untuk sesi dah ni. Okey, terlebih dahulu terima kasih Dr. Mardiana kerana membenarkan untuk pihak SSL, Wakil Jawatan Kuasa SSL untuk memberi sedikit penerangan berkenaan SSL, Safe Surgery, Safe Life program di Hospital Tanah Aminah Johor Bahru. Saya rasa kebanyakan ramai daripada yang hadir adalah paramedics, matron, sister, staff nurse atau MAs. Dan tanpa membuang masa kita teruskanlah ya. Okey. Apa dia Safe Surgery, Safe Life? Ini adalah sebahagian daripada konten ataupun isi ceramah hari ini. First one is overview, introduction, and then a bit of KPIs on surgical safety. Number 3 is strategies to improve surgical safety. Kita akan sentuh juga berkenaan dengan SSL checklist version 2.0 and sekali sebahagian daripada program audit compliance SSL Hospital Tanah Aminah yang telah kita jalankan sejak 2019 hingga 2022. Okey. Sedikit overview, the overview of the SSL programs. Okay. This is based on the data from World Health Organization. Actually, the main program of SSL is under patient safety, which is a quality program, which is introduced by WHO, and we started to have SSL in Malaysia, if I'm not mistaken, in 2008. Okay, and then implemented, actually they tried to implement it in 2010, but it's not really a takeoff, only takeoff in 2018. So this is based on the patient safety program quality, and SSL is one of the component. Okay, other component is, for example, like the incident reporting, blood transfusion error, patient prevention of patient fall. All those things is one of the components, some of the components in patient safety. Okay, directly to SSL. All these things from the volume of surgery. Okay, if you can see from the slides, total surgery globally, this is the data from 2012. We have about 312 million operations. Okay, that is mean global surgical rate is about 4,000 plus per 100,000 people per year. In Malaysia, you see in 2010 we have nearly 1 million, and in 2016 from the data we have more than 1 million of total surgery in MOH facilities. Again, when you have so many surgeries, this will give rise to certain problems regarding the surgeries, which is what we call as adverse events. If one of those adverse events as Showed here is surgeons operated on wrong side of brain, retain sponge or retain instruments inside the operating site. Okay, and some of the surgeons taking wrong kidney or wrong side of operations. Okay. So a bit introduction. So adverse event. What is adverse event in surgery? And adverse events is all those unwanted event which occur during surgery, and this is an important issue globally, and many of which is preventable. So the safe surgery program in the started WHO in 2008 is to prevent these things from happening. The main objective is to improve surgical safety and prevent surgical adverse events as much as possible. In Malaysia, this is one of the patient safety goals, and it is one of those KPIs. If you can see from the slides, it is included under KPI number 3 and number 4, which is number of wrong surgeries performed. Okay, and the target is 0 case for wrong surgery, and KPI number 4, which is number of unintended retained surgical items, which usually we try to target 0 cases for the category 2 and 3, which is the sharp needle and instruments and also soft goods. This is all these things is under retained, unintended retained surgical items. So learning from the past, all these things, wrong surgery, you can see from this data, which gathered in 2018, presented in 2018. This is wrong surgery reported in Malaysian patient, which is average about 4. 2014 we have 1, and then 2017 we have 5. Okay. Unintended retained body, foreign body, from the graph here, 2014 to 2017, as you can see, a still high number of retained foreign body reported in Malaysia. So what are contributing factors based on the RCA reports that have been gathered through the MOH? Most of the time, the cause of wrong surgery is due to ineffective use of checklist. Okay, no site marking or no operation site marking that is done pre-operatively, either right or left sides, from surgeon factors or staff factors, long working hours, and also fatigue, lack of concentration for long operating hours. Some of the surgeons, which is there's a miscommunication, can cause operating without knowing the patients, because due to miscommunication between the staffs or the doctors involved in the operating theaters. Some of the team members in the operating theaters, some of them, although they are supposed to be in the team, but non-involvement of all the team members makes these things, certain adverse events may occur. Other than that, when there is change of procedures, late consent taking, especially taking when patients is already in the OT, or it is all those adverse events can occur because the consent taking. I mean, different procedures need to be done for completion of the surgery. Lastly, but not the least, is the wrong surgery also can be due to a lack of experience from the surgeons or team members in the operating theaters. The other things that we are looking into is unintended retained foreign body. Okay, most of these things, especially during operations when involve when major operations, the swabs, the causes. Okay, that's why swab funding, swab counting, pre and post operative is very important, and very important to document all these things to prevent unintended causes left in the patient itself. Number two, failure to document any inserted gauze. This is usually in operating in the operations where the there's a lot of blood, especially abdominal, operating in the cavity like abdomen and thoracic, and there is got some a lot of blood. Then when they insert the gauze to pack these things, it might be left inside. So that's why counting of the gauzes, the swab counts is very important to prevent these things to happen. Some surgeons, they might took the gauzes from the nurses, the male trace by himself, then without the nurses, the scrub nurses knowing of that the gauze is taken by the surgeons, and it can be lead to left inside the patients if the counting is not done correctly. Number four factors that these things might lead to is inadequate passing over, especially when the shifts change between the scrub nurses for long surgeries, and also sometimes the assistant of the assistants, the runners changing within the shift, that can cause problems with the record of the number of causes or instruments that being done with the surgery. So what's the strategies to improve this surgical safety? Okay, the most important is awareness of these things, safety thinking, safe practice, and also the systems that involve safe system and safe culture. So all these things is the purpose of safe surgery, safe life programs. This is the main objective for safe surgery, safe life programs, for us to maintain the try to get safety, patient safety, and prevent all these adverse events. This strategy, there is 4 strategies to go about these programs. Okay, the first one is the use of perioperative checklist. With the purpose of this checklist is to provide simple, efficient, and priority checks, effective communications between the staff, especially from operative, the nurses that are involved in sending patients to the from the ward to the OT, okay, and then from the reception nurse that receive from the nurses from the ward. That is one, okay, and the other one is from the receptions towards the runners that involved and the team involved, the anesthetist, the GNS in the operating theater itself. And after the operation finishes, the communication between the recovery nurse and the GA nurses and surgeons and anesthetists, and then up to the from the recovery nurse back to the staff nurse that take patients back to the ward. It improve teamwork means that the teamwork mainly in the operating theater itself, from from the PPK, the nurses, the runners, the scrub nurses, the GA nurses, the anesthetists, surgeons, and the assistants of the main assistants of the surgeons or the secondary assistant of the surgeons. All this need to be good in communication and teamwork to manage the patients, to do the surgery, to make sure that the surgeons can do the surgery without adverse events. Ensure consistency in patient safety during surgery, okay, with those effective communications, okay, correct surgical procedures, and so on and so forth. And all these things will improve the safety culture of the teams and the staff involved in treating the patients. This is the famous Swiss cheese model, just to show you that communication, improving communication, teamwork, ensure safer surgery. Okay, the middle cheese is actually, if we'll check on to check the correct communications between the first and the last one or the third one, to check whether, yes, hello, okay, just to check whether there's any correct documentation or correct patients, or any problems between the documentation, the patients, and the surgery itself. Okay, and I'll try to brief a bit about SSL checklist. We got two versions actually. Previously, version 1, and the latest one we have is version 2. That's why you have this version 2 now. Okay, and these things is consists of 4 components. Okay, if you look at the SSL checklist, there are 4 main components. I can divide it into pre-operative checklist. That's the first component, which is from wards to the reception nurses. And then the second component is operating team checklist. Operating checklist is the GA nurses, anesthetists, and surgeons, and the runners. And there's concurrent important checklist, which is swab and instrument count form. Swab and instrument count form is actually, we have before the usual swab instrument count form, but now it is incorporated into the checklist to make a better documentation and easy audit data. And the last component is the pre-discharge check, which is involving the recovery nurses and the nurses, the runners that take patients back to the ward. This is from my one of my colleagues, Dr. Muhammad Anwar Abdullah, when they do this SSL SSL guidelines, which is it is the responsibility of the surgical team leader to participate and ensure the usage of this checklist. Okay. So the responsibility mainly falls to the surgical team leader, actually the main surgeons. Okay. And it is the responsibility of the checklist coordinator to ensure the checklist is complete. Who is the checklist coordinator? Mainly in this SSL program will be the runner from our side. The checklist from the SSL version 2 is the staff nurse or the runner in the operating theater. And lastly, it is mandatory to use a checklist regardless of situation, whether it is emergency surgery, life-threatening patient, or elective surgery. The main issue here is that there are some argument that in life-threatening and emergency surgery, the checklist is make the treatment or the surgery become maybe delayed and things like that. But it's actually the checklist still can be done even in life-threatening or emergency patients. For example, in this hospital, we have in surgical and trauma patient where the patient have to come immediately from ED straight away to general theater. So what are the barriers that has been identified? Okay, mainly one is the awareness was a staff. Okay, why this happens is because of the insufficient coverage of training, ineffective training, non-understanding of importance of program, and the benefits of the checklist. Some of staff doesn't really believe in this checklist because it can cause it just causes more works, more paperwork to be done, and this also can cause problems in or barriers in implementation of this checklist. Secondly, is unfamiliar with the use of checklists, and of course, sometimes it can be time consuming, but for these things to be successful, the importance of this checklist of this program is very important for us to achieve the patient safety. And using checklists as a tick box exercise, this is the implementation when they did try to form the checklist, try to make it as easy as possible, try to limit all this difficulty in understanding and what the filling up the forms. That's why certain things we need to fill it up, or certain things and the tick box and things, those kind of things can be a barrier to implementation, and they have tried to minimize this these procedures. Okay, lastly, mainly as I said, it's because of all these quality programs. Main problem is resistant to change. It's not only at the lower level, can also occur from the top level, from the surgeons down to the medical officers, the registrars, and down to the nurses and supporting staff. Lack of safety culture. Yes, most of us is we feel that safety of the patient is very important, but sometimes the culture need to be promoted and repeatedly need to be told and be aware of this safety culture in the treatment of the patient in the hospitals. The other problems, I think this is the least problems I suffer from leaders. I think most of the administrations, hospital administrations, even in the KKM, all have that known that the importance of patient safety programs and the supports of these things in terms of motivational or moral support is quite good. The only thing sometimes is the implementation or the communication from the top towards the second level of the staffs to the like the surgeons, anesthetists, of the pakar, or the specialist that is a bit lacking, and that's caused the lack of awareness, lack of the knowing that this is important to ensure successful of this program. A bit of the studies that support SSL, which can the checklist can improve the outcomes. This is a study from British Journal Anesthesia in 2012, shows that the overall death rate was reduced from 1.5% to 0.8%, and inpatient complications from 11% to 7% from these studies. Okay, so it is equally applicable to those undergoing urgent surgery or emergency surgery, and improve compliance with standard safety measures in a timely manner. And the checklist has shown that it is a valuable prompt to focus the team and even in extreme emergency. Another studies, this is shows that use of surgical safety checklists and improve communication and reduce adverse events or complications because of surgery. It may prevent more than half of the communication failures from occurring by orienting the team to the individual patient, alerting each member to potential complication, and encouraging team members to voice concerns when they notice an error occur. Okay. We also can lower rates of risk-adjusted morbidity, as evidence shows that a correlation between increased teamwork and a lower frequency of errors during an operation can be improved with this communication and reduce the complication of surgery. I will be sharing with you all a bit of what we have done from 2019. Okay, when we started this audit in HSAJB 2019, we have one audit which involved about 432 samples from 11 departments. And 2020, we have a audit of 359. Okay, and lastly, in 2021, I think we did a cross audit. This is just small samples because of the COVID and things like that. We couldn't have this complete audit. That's why we have just a cross audit in 2021. Okay, the audit findings. Okay, there is improvement. Okay, overall there is improvement. If you look into each component from patient profile, pre-transfer check, down towards staff informations. Okay, this is the percentage that we have from the audit findings from 2019 to 2021. Okay, our main problems usually is basically the patient profile because of the some components of dosing. We'll show it later. Okay, and as you can see all those things inside during the operating or in the operating theater proper, the compliance is quite good, but still we still have to improve. Okay, as you can see, average is the compliance about 60 to 80%. So we need to improve those things. We try to improve these things in the current settings. So this is compliance rate by departments. Okay, there's much improvement. Okay, in terms of the compliance rate. Is in 2019 to 2020, but there's still space for a lot of improvement. Okay, pre-surgery has improved a lot, nearly about to 100%, 99% and above. Okay, but other departments is still lacking in terms of those. But we achieve fairly good results. This kind of things. And we hope with these awareness programs and our frequent audit or regular audit, we can improve these results of overall compliance rate. And from the audit, some issues that identified, okay, as I mentioned before, regarding patient profile, most of the problem is in they didn't fill up the body weight, contact person, handphone number is usually just left empty. So that's why these things usually when these things, even one component of the checklist is not filled up, then it will be non-compliance. Okay, incomplete markings of for all the items in the checklist, incomplete final swab count, and again because specifically the nurses that have to sign or the checklist have to have the jobs. So initially the jobs, the official jobs of the staff nurses is not there, then it will be classified as a non-compliance. So the action plan, as we have listed, daily audit by the sisters in ward, OT, and we try to do unofficial or informal regular clinical audit, awareness activities that what we are doing now, and we try to make it is more frequent and cover more staffs in the hospitals with CME and CNE, and of course we will try to inform the audit findings to the staff, to the staffs and to the management, and try to get input how to improve these results. As a conclusions, okay, it is everyone has a role in trying to get towards patient safety for the successful SSL programs in the hospital. Okay, and the culture of practice the correct ways and correct the incorrect practices that has been that's already in the culture need to be change and need to be improved. Okay, and patient safety is not just for the pengarah or Dr. Madiana and the quality team, but it's also for everyone from the lower level of PPKs towards the top level, the surgeons, head of department, and also the pengarah hospitals. I think that's about it about my short lectures. This is just a reference. And I would welcome any question and try to make it informal discussions for all those participants who want to know about SSL. Okay. Any questions? Any ideas, any comments regarding SSL, especially from the nurses that have problems or you want to highlight? Okay, SSL programs. Basically, from my point of view, the commitment, tentang komitmen daripada staff, so far dah much better in terms of commitment daripada paramedic, daripada staff nurses, daripada matron and sisters, much better compared 2019, the committees. Terima kasih, thank you to you all which have supported the committees that has been trying to get the documentations and audits of the SSL programs. But still, I think the commitment is still not up to the adequate level. If we can improve in terms of the commitment, in terms of the awareness of this SSL towards the patient safety, then it'll be much better. Any comments, guys? Ada apa-apa soalan ataupun pendapat yang you all nak utarakan? Senyap semua. Encik Arif. Dengar. Encik Arif. Arif Abdullah.
Sorry bos, tekan.
Yelah kau.
Jika ada soalan boleh diajukan di chat box juga ya. Thank you.
Kita akan adakan satu program. I think this is one of the first program because sejak saya jadi chairman ni sejak 2019 dan kita ada COVID, so banyak program yang kita rancangkan kita dapat lakukan. Keduanya of course lah sebab budget. Okay. Kita akan ada program pada hari Khamis ni which is limited to about 60, I think 60 participants sebagai SSL Day. Just to kebanyakannya adalah daripada staff nurses and sisters. Hari Khamis ni lah just untuk create awareness and ditahu tentang objektif tentang kepentingan SSL ni lah. Saya tahu memang program-program quality ni kadang-kadang boring ya, okay? Sebab dia just lebih kepada menambah kerja kita ataupun lebih kepada paperwork yang kita tak nampak sangat apa dia punya advantages ataupun reward kepada staff. Tapi benda-benda ni adalah benda yang kita perlu buat, okay? Dan juga dari segi untuk lebih kepada kepentingan untuk documentation yang kita boleh base atau kita boleh based on the data documentation, then kita boleh check back on our what is our quality tentang servis yang kita berikan lah. Kemudiannya,
Saya just nak share untuk tahun ni, untuk Safe Life ada satu je lah case unintended retain foreign body yang melibatkan gauze, di mana patient pergi ke Whipple procedure dan masa tutup dia from 4 noted 1 missing. So mereka dah buat x-ray, nampak tak ada, and afterwards proceed dengan CT scan pun nampak tak ada lah. So RCA juga, comment daripada HOD juga ada yang mengatakan adalah cara apa di mana dicadangkan untuk menggunakan abdominal pack rather than loose gauze.
Kebanyakannya all these retained gauze, most of the problem is because of the gauze is quite small. That's why usually when you do a packing using gauze, especially in the cavity, in abdomen or in the thoracic cavity, it might be left inside. One question, this gauze, did we find out where is it?
But then afterwards buat CCT, everything memang tak
adalah, it's not in the patients. These things usually, the gauze sometimes is the count itself. That's why the importance of the counts. The counts of each gauze tu ada berapa, ada 10, kena count, kena saksikan, kena listing dia satu. Sometimes when they pack, kurang satu gauze, satu. Yang keduanya adalah memang mudah, memang kalau dalam cavity as usual, tak lama dah kita jelaskan yang kalau kita nak pack, we use this abdominal pack rather than gauze. But sometimes because it's in a stress situation when you want to auto bleeding, we just give whatever available at that time. It's still, I think still gauze is still being used to pack, like especially in the small spaces and things like that. But I think the most important is the count. The scrub nurse and the runner have to be very careful with those things. And I think that from the incidents, they have checked everything. They realize is intraoperatively is the gauze count is not correct. Try to find it out using II, X-rays and things like that. But unfortunately, they cannot find those kind of things. The most probably this cause is either due to miscount or the pack is less, it's not enough, maybe 9 instead of 10, or during the procedures the gauze is outside, then it is being thrown away and things like that. That's why it's not there. I don't think it is inside the patient of this.
Only one je lah.
My experience in medical legal, because the one that usually is in delivery. Okay, it is not delivery, and they still, although they said that when they want to pack vaginal packing and things like that, they use long gauze. You see, it's not a short gauze that has been done, but still there will be cases of retained gauze inside the vagina because of vaginal pack, and you'll be surprised because the vaginal pack is quite long. You see, it can be quite long, but it still can be left inside and only realized after months of those things. The thing is that the problem of those things is the gauze, the vaginal pack or the gauze pack, the roller gauze that they use is not really, they just put in the cupboard without the numbers. So when they want to use, they just take those things in three pieces instead of like, okay, you take one bag with 10 gauze, small doses, one bag, let's say 10 gauze there, 10 gauze, bring it to the patient so they can know those kind of things. The only thing is that they just do it, insert, and then they cannot count the process that has been used from the packs and things like that. And then it was left inside one patient for, I think, almost about 6 months. Okay, that's become a medical issue. Other than that, I think detained foreign body, orthopedics is one of the culprit. All these things is not usually is because of broken drill bits. That's famous in orthopedics. We are trying to improve those kind of things, but sometimes when it is broken inside bones, try to remove those things, make it more harmful, morbidity to the patients, and that's why some of those things we decided to left it inside. Okay. Any other comments?